Hi, everyone. A very good evening to everyone who has joined us, and welcome to today's webinar. It's entitled What's New in SARS Antigen Testing, the Global Pipeline and Training Do's for Quality Testing. I'm Rajeshri Sen, Senior Manager, Programs and Partnership from Find India's office, and we are excited to have you join us on this fifth webinar in the series that we are hosting. We're very thankful to our donor, the Bill and Melinda Gates Foundation, for enabling this. In the COVID era, Find globally has been executing multiple initiatives and projects. We are continually updating our database of COVID tests in development and commercialized. We are also conducting independent evaluations of molecular tests and immunoassays in collaboration with the WHO and multiple partners worldwide. And of course, Find and the Global Fund are co-conveners of the Access to COVID-19 Tools, or the ACT Accelerator Diagnostics Pillar. So for today's session, we have our very own Dr. Gillian Sachs. So Gillian joined Find in 2019 and is currently the head of the Pandemic Preparedness Program. Gillian has spent the past decade supporting the implementation of affordable diagnostic and monitoring technologies in resource-limited settings to combat infectious diseases. She has previously held positions at the Clinton Health Access Initiative, the Earth Institute at Columbia University, and a joint fellowship at Rutgers University and the Africa Health Research Institute. Also with us is Dr. Andre Trollip. He's a technical officer in Find South Africa team. So Andre started his career as a medical microbiologist at the South African Institute of Medical Research, and his interest in diagnostics saw him transition to research and later academia. He has over 25 years of experience in developing and evaluating TB diagnostics and joined Find in 2014. Most recently, Andre has been putting together Find's online courses on COVID-19 testing, which a lot of you may be aware of, and also now the antigen training package, which has been developed in collaboration with the WHO. And we are very lucky to have a first-hand preview of this from him. Few housekeeping messages. If you have any questions, please put them on in the question and answer box. And also just wanted to flag that the session will be recorded and available on our website later for your comfortable viewing. Over to you, Gillian.
Great, thank you for the kind introduction. I hope you can see my slides.
Yes,
Great.
we can.
So good afternoon, everyone. I'll be starting off today giving you an update on global policy related to the use of antigen RDTs for diagnosis of COVID-19. And I'll also touch on the pipeline of products that are available. So just as background, so that we're all on the same page, antigen detection tests are now becoming available, which are in immunoassay format, mostly in lateral flow format, or also known as rapid diagnostic tests. These tests are able to detect the antigens of the SARS-CoV-2 virus, and most are used with upper respiratory swabs, and the results are generally available within 30 minutes. The majority of antigen RDTs that are currently available target the nucleocapsid protein and are compatible with nasopharyngeal swabs. And here's just one example of one product. So in September, which is a little while ago now, the WHO released some interim guidance on the use of COVID-19 antigen RDTs. And since then, many countries have set their own policies. So I'm just going to walk through some of the key points of the guidance released by WHO. So antigen RDTs that meet the minimum performance requirements of greater than 80% sensitivity and greater than 97% specificity compared to NAT can be used to diagnose SARS-CoV-2. And we'll discuss briefly why these performance targets were set. It's also noted that antigen RDTs should be conducted by trained operators in strict accordance with the manufacturer's instructions for use. And in the second half of the webinar, Andre will touch on some of the important aspects of training that need to be considered. So the interim guidance from WHO describes 5 scenarios in which antigen RDTs should be considered. The first is to respond to suspected outbreaks in remote settings or institutions or semi-closed communities where multiple positive antigen RDTs results would be highly suggestive of a COVID outbreak. They also recommend that these tests can be used to support outbreak investigations where antigen RDTs can be useful to help screen at-risk individuals and to support the rapid isolation of positive cases. They can be used to monitor disease trends in the community, especially for essential workers, and where there's widespread community transmission, which is the context in many settings right now. RDTs can be used for early detection, isolation, as well as for contact tracing. And the guidance does note, and we can come back to this, that testing of asymptomatic contacts of cases may be considered, even if the specific instructions for use for the product does not specifically state that the test can be used in asymptomatic individuals. And I'll touch on why this may be possible. So, in thinking through a rollout strategy, it's important that you feel confident in the performance of the antigen RDTs. And so what the guidance currently states is that if possible, you should initially consider deploying antigen RDTs in settings where NAT is actually available. And that way you can have some quality assurance and quality control to confirm some of your positives, confirm some of your negatives, and really understand how the tests are performing in your intended setting. If NAT confirmation is not possible, it's important to triangulate with clinical symptoms in order to confirm result validity. And then lastly, and this is something that we really are currently generating data on to figure out if this needs to continue to be the case. WHO at this time says that the use of antigen RDTs is not recommended in low prevalence settings because of imperfect specificity, although there is emerging data that perhaps the rates of false positives are not as much of a concern as we might think. And so in order to select products, there's a lot of factors that need to be considered. One is the quality of the data that's available that has been used to validate the test, the reported performance of the test independent from the manufacturer, the actual manufacturing of the product and whether it's regulatory approved, the capacity of the company to supply the volume of tests that you need, as well as the distribution and technical support that may be available by the company. It's important to consider the shipping and storage requirements of a product, what specimen collection requirements are needed, whether the test kit contains those specimen collection requirements or not, the cost of the test, as well as the completeness and clarity of the instructions for use. And I think Andre will likely touch on a lot of these factors in the second half of the webinar. So what do we know about performance? FIND has been working to provide independent evaluations of many antigen rapid tests, and our efforts are widely noted on our website. Today, I'm just going to be presenting some data that we've generated on the standard Q and the PanBio assays, which are the 2 tests that have been approved through the WHO emergency use listing procedure. So FIND, in collaboration with partners in Germany, Brazil, and Switzerland, performed some independent evaluations of this standard Q assay. And what I'm showing you here on the top is the sensitivity estimates from each of the individual studies, and on the bottom are the specificity estimates. And then we've also used a random effects model to combine estimates across countries, since we know that the results are slightly variable, so that you can see that across the 3 different settings, we have an estimated 87% sensitivity in reference to PCR, and an overall 99% specificity in reference to PCR. If I go through the details of these evaluations for both the PanBio and the standard Q, this is a lot of data in a table, but On the left-hand side, you can see the performance of the PanBio in 2 European settings, which had variable positivity rates. So in Switzerland, we did this in a context where positivity was quite high, close to 20%, so that we could reach our sample size of about 124 positive PCR samples. In Germany, the PCR positivity rate was much lower, about half. And so in order to reach that same target of 100 PCR positives, we screened over 1,000 individuals. But you can see that despite the difference in positivity rates, the clinical sensitivity was quite consistent across the 2 settings. And then if you drill down and look at the sensitivity in specific groups, so in individuals who reported symptoms onset less than 7 days previous to when they had their sample collected, or individuals with PCR viral loads that correspond to less than or equal to a CT value of 33 or 25. You can see that the sensitivity does vary, and with individuals with increasing viral load or decreasing CT, there's increased sensitivity. Similarly, the specificity was quite high in both settings, and there was no invalid results. We also did similar studies for the standard Q in Brazil, Germany, and Switzerland. And what you can see here is, again, there's relatively consistent performance across the 3 countries. The positivity rates do vary, and the same trend can be seen, that sensitivity increases according to either more recent days post-onset, symptom onset, or higher viral load. And specificity is quite high, and there was minimal invalids. And as I noted, all of this is available on our webpage. So the data that we're generating, as well as the data being generated by others, is indicating that the most sensitive antigen RDTs are likely able to detect almost all infectious cases, although this is preliminary, which are those individuals who have the highest viral load. So in this graph, what you can see, and this was generated in the Netherlands, is they plotted the ability to culture virus from an individual sample according to the viral load. And then they looked at whether the antigen test that they were looking at, how sensitive they were in detecting that individual as being positive or negative. And what you can see here is that generally the Abbott and the SD would be able to detect the majority of individuals who actually have culturable virus, which is good, right? For public health considerations, those are the individuals who we really want to capture. And then the more important point of antigen RDTs is that really they enable rapid turnaround times. So you can actually take same day action and initiate contact tracing. And there's been some modeling done that perhaps you can increase from having perhaps 33% of individuals who are able to be contact traced and chains of transmission being followed up to 97% when you have the most sensitive RDTs in use. So this is just a cartoon to sort of summarize all of this, which is to say that yes, the detection limit of RDTs is not as high as with PCR, but that perhaps the trade-off in sensitivity is counterbalanced by the fact that you can detect people immediately, and you may be detecting the cohorts who are most contagious to be able to stop chains of transmission. So as I noted, that there's a lot of antigen RDTs in the product pipeline. So this just shows you from left to right the tests that are in early development versus tests that are already approved for use in various countries. And you can see it's quite a rich pipeline. And the expectation is that perhaps some of the tests that are still in development may have improved sensitivities or may be compatible with different sample types. But the products right now, there's a huge plethora of different products available. And their performance does vary, so it is important to keep that in mind, to find independent data on their performance before you select them for use. And I know that there's a rich pipeline of products being validated through ICMR in India, so that's useful for your product selection. So to summarize, basically, antigen RDTs are expected to be able to help countries expand access to diagnosis where PCR testing may be limited. So PCR testing can diagnose acute infection and is very critical. And these tests were able to be developed quite rapidly, and they do show very high clinical specificity and sensitivity, but they do require laboratory infrastructure, highly trained staff, and depending on sample transport and throughput in the laboratory, turnaround times may be long, in which case, despite the fact that they are high sensitivity, results may not be available in a time when they can be of clinical utility or even public health utility. And thus they may be challenging to rapidly scale in many resource-constrained settings, and even in high-income countries, PCR capacity has really been tested to its limits. So antigen RDTs may be a very useful complementary way to assist in enabling acute diagnosis. They do typically perform less well than that, but we are seeing that most of many tests that are coming to market can at least perform to levels that are specified by the WHO target product profiles, which is at least 80% sensitivity and at least 97% specificity. And we are seeing that many of the products actually are more specific than that. They can be deployed in decentralized settings, including clinics and in communities by healthcare workers or perhaps even trained lay providers. And they provide rapid results in under 30 minutes. This is just an example from Europe, from the EU and the European CDC, that sort of maps out how you might consider using these tests. So depending on if you want to test symptomatic individuals, are you in a high prevalent setting or are you in a low prevalent setting? If so, in their guidance, they say antigen RDTs are likely helpful for any individual who is symptomatic, even in low prevalent settings, ideally within 5 days after the onset of symptoms. And the reason that you would be doing this testing is really to control transmission, mitigate the impact of the outbreak, identify new clusters, and to monitor trends. Whereas when you're thinking about screening asymptomatic individuals, if they're asymptomatic and you're in a low prevalent setting, the EU is saying perhaps these antigen rapid tests are not necessarily the best choice. Whereas if you're in a more high prevalent setting where you want to do more recurrent screening, then antigen RDTs may be useful. And this is meant to sort of just be a framework for you to think through how this might apply in your context and not necessarily to be prescriptive. So just to conclude this part, there's likely substantial variability in performance between antigen RDTs. Therefore, validation of individual products is critical, and performance is really just one factor that should be considered when selecting specific products. The data I showed you is that Standard Q and PanBio do meet the currently recommended sensitivity and specificity targets across many different countries. And there's other data from that FIND has not generated that also supports that point. And these products are approved for use through the WHO EUL procedure. And therefore, given the rapid result availability and ease of use, we expect that antigen RDTs are likely to offer the potential for early diagnosis as well as interruption of chains of transmission, despite their imperfect performance. And then in the future, we are starting to look at, so all the data that I showed you today is for the use of antigen RDTs using nasopharyngeal swabs. The Abbott PanBio is now approved for use with nasal swabs. And perhaps the Standard Q will also become approved for use with nasal swabs. And there are some US FDA authorized tests that are also approved for use with nasal. So we expect that likely the use of this sample type may facilitate their uptake, as it's a more comfortable sample to collect and likely can facilitate more ease of use. And then we and others are really actively trying to do more operational research now on the impact of antigen RDTs for epidemic control and clinical management, performance, as I said, is just one characteristic. Now that we have some products, we really need to see how how feasible and acceptable and useful they are in their intended use settings. So I think with that, I will close, hand it over to Andre, and then I'm happy to answer some of the questions that are already coming up in the chat box. Thank you.
Perfect. Thank you, Jillian. And it's heartening to know and see the data around antigens, because as you know, in India, we have been scaling up antigen testing by leaps and bounds. And there's been a lot of debate as to whether it's the correct strategy for the country, especially considering different sensitivities and the perceived lower sensitivities. So it's really great to see that data. And over to you, Andre. Thanks.
Oh, you can hear me now? Can you hear me? You can. I'm sorry, I've just lost sound.
We can hear you. We can hear you, Andre.
Oh, you can. Okay, thank you.
Yes.
Okay. Well, thank you for the opportunity to talk to you today. It's a great honor. And so without that further ado, let me get started. So today I'm going to talk to you a little bit about the SARS-CoV-2 antigen rapid diagnostic test training package that was launched by FIND and WHO just a few weeks ago. But before I get to that, I think it would be important for me just to touch on a few other things, and primarily around quality and the importance of quality in antigen testing, but also to talk a little bit about the essential components of quality assurance for those of you that are working in laboratories specifically. And then I'll focus a little bit on the components and the structure of the training package itself. And similarly to Jillian, we'll take questions afterwards. So why is quality important for RDT testing? And I think from our experience with HIV testing, many years ago, there was a realization that healthcare workers at the front lines that were doing RDT testing were really critical in ensuring that patients were identified and put on, and managed correctly. And so that experience with HIV, and I guess to some extent with malaria as well, really extends now to SARS-CoV-2 for COVID testing. So a quality test is really an accurate test, it's reliable, and it's performed in a timely manner. You as healthcare workers, many of you on this call will be responsible for performing these tests, and you have a massive responsibility. When we refer samples to the lab, often there's a whole quality management system in place to ensure quality. But for RDT testing that's happening in healthcare facilities, as an example, there is no such system. And so the quality comes down to the individual. And so it's really important that you have the responsibility to ensure the quality of the results of the tests that you're performing. So what are the consequences of inaccurate results? Well, they're obviously far and wide. So false positive results can label an uninfected person as being infected. And as we are all so familiar with these days, this can result in quarantine. There's stigma attached to that. It's very stressful. Any of you, and I've had this experience where you've been in contact with someone that has had COVID, will know what stress that can cause. So we really don't want to do that. And similarly, false negative results mean that we miss the infected person, and that in itself has very negative implications in that individual is then able to infect others and spread the disease in the community. So we want to avoid false positives and false negatives when doing our antigen RDT testing. So where do these testing errors occur? So I say they're widespread, but where do they occur? Well, they can occur anywhere within the testing process. This is right from the really from before we even start testing, how we store our kits, how we select the right people for testing, collecting the correct samples. And Gillian touched on this, and we have to emphasize this again, that correctly collected samples will give us good test results. The errors can occur while doing the testing and not following the procedure. And I see this a lot in the field with tests are relatively simple. And so people think they remember how to do them. And then before long, they're not following the test procedure, not following and performing quality controls according to the manufacturer's specifications. Another reason that we will not detect testing errors. And then, of course, after testing as well, just reading and reporting. And we'll touch a little bit on this later on, but sometimes these tests can be challenging to read, and the results can be reported incorrectly as well, which can affect the patient outcomes. Given that the rollout of the antigen RDTs is taking place within the pandemic itself, there really isn't a time for establishing a full quality assurance system around these tests. And so we have to emphasize the fact that training and supervision of the users is critical to ensure the quality of those results. And if we don't do that, we are going to get some of those false positive and false negative results that I spoke about. Also important, and Gillian touched on this as well, is for countries to select the correct RDT for their situation, which we won't be dwelling on too much today, but I advise you again to look at the data that we shared earlier and to help use that in guiding you in your decision-making process. So the SARS-CoV-2 antigen rapid diagnostic test training package was launched by FINE and WHO some weeks ago. It's really a structured, comprehensive collection of training resources and tools to support institutions to organize, run, and evaluate training for healthcare workers who are performing tests. And the target audience is primarily healthcare workers in hospitals, clinical facilities, who may be doing antigen testing for the first time, but also it includes laboratory workers that may have experience at running antigen tests or other tests for that matter. So the objectives of the training package itself is really to equip the healthcare workers with both the theoretical and the practical knowledge to safely and accurately collect the samples, conduct the test, interpret the test results, and understand the implications of those results on patient management. So I think what you can see is that the training package is trying to address all of those areas where errors can occur. And again, I would like to emphasize that this is not just a theoretical training, but also has a practical component, which I'll stress in a moment. The package really is designed to address two groups of training. The training of trainers, for those of you that are familiar with the term TOT, training of trainers. So these are training for people that would then go on and train someone else. That's referred to as training of trainers. And then also for the training of the end users, the people that will actually be doing these testings, be they healthcare workers at clinical facilities or laboratory workers, such as many of you on the call today. And the way that we do that, so the modules that the training will cover, there's 10 of them. I'll go through them in a moment, but for the training of trainers component, there is actually an 11th module, which actually provides some information, content on how to train others, if you're not familiar with that. The content of the training package itself covers really all of the theoretical knowledge that were required to run the test properly. So we provide some overview of SARS-CoV-2 testing, touch on the testing strategies, then discuss quality, and a few of those slides which I showed earlier, in fact, from that module. A huge emphasis on safety, particularly, for us in the lab who are very familiar with doing PCR testing at the moment, these things might already be in place. But at many clinical facilities, this is new. And so there's a strong emphasis on the safety component. Sample collection, again, for users, just to go through the procedures, ensure that the nasopharyngeal swabs are collected in the correct way. Then something on supplies and managing supplies. Again, it may be very familiar to you from the laboratory perspective, but for many that are at clinical facilities, this is a new function which that we need to have some training on. Then information on performing a generic SARS-CoV-2 test, and the training materials. I'll talk about the customization in a moment, but this would be the part where you could insert the specific information regarding one of the tests or more that you're introducing at your testing site or at your laboratory. Second to last point is around the use of data. So the data from the SARS-CoV-2 RDT test needs to be collected for quality assurance purposes, but also more generally, and there's a whole module that's dedicated to that. And then finally, assuring the quality results. This is around performing the controls, EQA, PT, many of the things that we associated with quality assurance. This slide just really covers what the package consists of. So the first component is the trainer's guide. And for those of you that will be involved in training of others, this is a key resource for you. I suggest that you go through that very carefully. The trainer's guide will give you some key tips on setting up the training itself, help you make sure that you have everything that you need to do the training, and also just guide you through, particularly around the competency assessment and the practical components and how to go about doing those. Included in the package are some checklists. So for instance, if you're doing sort of site initiation visits, then you'll find some checklists over there, and there's a job aid, an example of one on the right-hand side there for generics. These can be put up at the healthcare facility to guide the users in how to perform the test. The logbook, which I mentioned already, very important for collecting the data at site. Also included in the package, WHO has made some videos available for us on specimen collection, specifically around nasopharyngeal swabs, as well as conducting an RDT, and some of these will be updated in the future as well. And the package together is to facilitate both face-to-face training, but as we are aware, we need to scale this up really quickly. Like the amount of healthcare workers that need to be trained is enormous, and doing this in a socially distanced way is going to be challenging to get to all of these numbers. So there's also a component in which we could use some aspects, maybe the theoretical components, in remote training and some more blended training. I did allude to earlier the fact that part of the training package is around the practical session and the competency assessment. Here's a lovely quote. So what I hear, I forget. What I hear and see, I remember a little. What I hear, see, and discuss, I begin to understand. And what I hear, see, discuss, and do, I acquire knowledge and skill. And so really it's this last line which we're trying to emphasize with this training package, that by actually performing some of these tests in the training session and then being tested on your competency to perform them, you'll acquire the skills that are necessary to perform the testing at your healthcare facility. The package is designed to be customized. We were just talking before we started today about how we could customize the training for one setting. So there's really two areas which I want to emphasize. So the training can be customized for the relevant audience. So here we need to include national guidelines. So you won't find a guideline in the training. We need you to put your guideline in the training and train your users on your guideline. If you don't have one, yes, by all means. And Julian showed us an example of what a guideline could look like, or at least the algorithm part of it. And you could put something like that in there. And the WHO interim guidance also provides some information on that. Also, that can be customized around your own safety guidelines, how you handle samples at your site, how you handle waste. These things need to be customized in the training so that it's applicable for your users, and we're not just training them on something that happens somewhere else in the world. And then according to your attendees. So as I've alluded to on a number of times, the training is both for laboratory workers as well as healthcare workers. And if you as a trainer are responsible for doing that training, you may want to customize that training for your healthcare workers. And in the user guide, we have set out some recommendations of what slides you can use within the training package itself, depending on the group that you're training. And so by all means, take the recommendations and use those to customize your slide sets. The training itself is expected to be delivered over half a day to a full day, and that will include the practical sessions which I alluded to. Of course, the time is going to be dependent on the scope of the training, whether you're using some kind of blended tool and whether, the trainees have gone through some of the theoretical components before the day. The number of facilitators available, this is really important. We're sort of recommending that you have one trainer to 5 to 10 users, so as to be able to facilitate the practical component. So it's going to depend on how many facilitators are available. And then, as I mentioned as well, whether remote or face-to-face training is your primary mode of conducting the training. A note on completion. So for many places, certification is really important for their end users. And so that is included in there, and there's a template that can be used for certification of the end users that have successfully completed their theoretical and practical components of the competency assessment. Just to be very clear here that this certification is not a FIND or WHO certification, and what we would request a country to do and the trainers to do is to use their relevant national authorities to offer the certificate of competency. Participants that are considered competent would have passed the theoretical and the practical components. The practical components would be how to collect the sample, how to perform the test, and as well as reading the test result and understanding how that impacts patient management. For those that have not completed the competency successfully, these will need to be retrained, and that will be another reason why your training could take a little bit longer if you need to retrain some of your end users. Very important, I guess, if not the most important aspect is where do we get the training package? So there's really 2 places. Here's an example on the right there. This is on the WHO Health Security Learning Platform. The training materials can be downloaded from there, and that's the link that's shown on the left-hand side of the slide. They're also available on the FIND website, and the FIND website mirrors what is available on the WHO site. So you can get the training package from either of those places. Currently, the training is available in English, and coming soon, some translations: French, Arabic, Spanish, Portuguese, Russian, and Chinese. And there are also some move afoot to add some additional video to the training package. So you might see some changes of that over time. A very important component, and I guess one of the most important things that I need to ask you to do today, if you are going to use the training package, and I really would suggest that you do in training for your lab and healthcare workers, is to please give us some feedback. As you can imagine, with the announcements and the availability of the antigen RDTs, it really did not take us a long time to put this training together. So we are in uncharted waters, as it were. So we require some feedback on the training curriculum, how you use it, what worked for you, what didn't work for you. That's the only way that we can make it better and ensure that other users benefit from your learning experiences. So to facilitate that, we provided a link on the website for where you download the materials. There's a feedback form there. It'll be very quick for you to be able to download that and give us some of your feedback. And we'll also include within the training package itself a feedback form for the users as well on how they found the training. So we would ask that if you're going to complete that for us, and we ask you do, if you could please also include those comments for us, and that would be very helpful as we look at moving this from its sort of 1.0 where we are to version 2.0. And finally, from our side, a very long list of acknowledgements. So I've led the development from FIND side, but really there's been a number of people that have been involved in developing of the material from FIND and from WHO. Really just shout outs to Jane and to Celine from WHO. Without their help, we would not have been able to put this package together. We've received a lot of technical input from WHO across the world, and you can see them there, as well as organizations such as ASLM. And then finally, just to say, the training materials that we developed lean heavily on the HIV and malaria training packages. And for those of you that have been responsible for implementation of those in your countries, you're going to see the similarities there. So we just want to call that out right up front, that this is not entirely new, and it follows some of these key documents, as well as the SPI training from CDC is another one as well. And that's really all I've got. I'm really happy to take any questions on that. I know that we really went through this very quickly for you, but happy to take any questions on the training package. Thank you very much.
Thanks, Andre. And it's this training package, just for everyone, it's on our website, and we've been very excited to roll this out. And any labs that are listening in and want to support us in on-site trainings, just get in touch with us, email Andre. I think this material is out there for just everyone to use. And Andre, quickly, I had a question while you were going through the slides. In fact, in India, a lot of the times, because of the rapid scale up of testing, there's been a sort of conflict between people doing testing and actually getting trained, especially on quality aspects related to the testing that they're doing. And a lot of the, especially antigen testing, it's quite new for a lot of the lab personnel who are doing it. It's a new disease. The tests are all new. So would you like to share a bit about your experience, maybe from South Africa, about how the labs are balancing the actual act of testing versus getting their people trained on the testing?
Yeah, so thank you for that question. So I don't have a lot of experience with this. This is only really rolling out in South Africa currently, and a few of the sites that are performing testing are really doing this within a research capacity at the moment. And in fact, Gillian and myself are on a call just after this, really to talk about some of those things. So I don't have a lot of experience with how that's looking for us in South Africa in terms of the general implementation. What I can comment on, though, really is what I had seen when I was doing implementation around HIV rollout of rapid diagnostic tests. And these were tests that have been really moved from the laboratory into clinical settings. So, and I think that's where the challenges with implementation of tests like this really arise. So the lab, as I've mentioned earlier in my slide, said already has the quality assurance systems and quality management systems in place to ensure quality testing. But it's really when you go into the field that things become a lot more difficult, because the users of these tests have not been trained in quality assurance aspects. And so that is where this training package is really important. And in fact, I would hesitate to say that if you as a lab person go through the training, you may think, oh, I know a lot of these things. But just to remember that you might not be the audience. The audience might be someone that is really not that familiar with the quality assurance aspects. Something that we saw a lot of in HIV, and I believe will happen a lot here too, is that you simply cannot reach enough people, and that what you then have is that sort of on-the-job training, where someone goes to a training, comes back to their facility, and then trains other healthcare workers to perform the testing. This can be problematic, right? Because in the process of transferring that information, there can be some errors introduced in there. And so these can manifest themselves in testing errors as well when there's on-the-job training. However, in terms of quality assurance for RDT testing more generally, what we really need to think of is a network that assures quality. So from a very central position, now whether that be at the laboratory or within the ministry itself, there should be supervision visits that are occurring, that individuals go out to clinical facilities and to labs for that matter to ensure the quality of the testing. We've included a checklist in the training package that they could use for those supervisory visits, and that would be an opportunity to both gauge who is doing testing and have they been successfully trained, and what is the quality of the testing more generally, looking at, for instance, the quality controls as an example. Andre.
Got it. Thanks, Andre. So there are quite a few questions that have popped up in the question and answer box, and I see that Gillian has been answering some of them. So quickly going to one of the questions, I think, which is very relevant for India and the stage that we are in. So Vasundhara Rangaswamy asks that in many places in limited resource settings, essentially it's hard for patients to come back to the care center, and a lot of the times a RAT is being used, antigen testing is being used. And in some cases, a single negative may not rule out the infection because of the stage of infection, etc. But in those cases, a lot of the times NAT is not possible. It's not accessible, or maybe it's such a limited resource setting where there is no access to the closest NAT testing. So Gillian, a question for you. In such a scenario, would you recommend repeating the RAT testing? And has there been any cost analysis done for 2-3 repeat tests? So I think 2 questions. One is, would you recommend repeating the RAT test? And is there any analysis which has been done on the cost benefit analysis of doing 2 or 3 RAT instead of 1 against the RT-PCR?
Great. So really important question. So there's 2 reasons why an antigen RDT would be negative in comparison to PCR. It's either you're early in the disease course, and so the viral load is low, or you're late in the disease course, and so again, the viral load is low and you've missed the peak. So in the scenario that you've just described, and you're saying that someone's coming late to present for diagnosis, if the antigen test is negative, likely if you wait and do another antigen test, they'll still be negative. And so in that context, I don't think repeated testing would really help to pick up a false negative in this context. In the case that someone's early in infection, so perhaps you're doing household contact tracing and you just went to a household right after someone tested positive, you might test their household members on day 0, and some people may test negative, and there's a possibility that they're still early in their infection. So if you tested them again 1 or 2 days later, and their viral load is increasing, you may then be able to detect them. So in that case, if you're finding someone early and you have a negative antigen RDT, a repeat test might help with those false negatives. When it comes to false positive antigen RDTs, and this relates to some other questions that people have been asking, there is also a consideration of if you are testing in a low prevalence setting, and so your pretest probability is low, and you get a positive antigen RDT, you may want to confirm that result using PCR. If you don't have access to PCR, then you could consider retesting using another antigen RDT. And our current knowledge shows that the likely reason for false positives is not due to true cross-reactivity or true false reactivity with something that's present in the sample. It's really just because the tests are imperfect. And so there is an expectation that likely if you repeat with another antigen RDT, you may be able to rule out some of these false positive results. So in that case, it could be quite useful. In terms of cost benefit analysis, I think this is a really important question. And I know of several groups that are currently doing these analyses. So I'm expecting probably in the next few weeks for more information to come out on that. But it is something important to keep in mind that these antigen RDTs are currently about $5 USD, and they're likely to come down, whereas PCR tests are maybe around 20 or 30 USD. So there is a substantial cost difference between the 2 products.
Got it. Thanks. And I'll just get in one more question for you because I see quite a few. One is how far are saliva or buccal swabs useful for antigen tests? That's, I think.
So the current data that we've seen is that the availability of antigen in saliva samples is quite low. And so the sensitivities of the existing tests are a bit lower when using saliva. There's not a lot of data on buccal swabs, and I think that's something that's being looked into. But for now, really the upper respiratory swabs of either the nasopharynx or the nostrils is the main sample type that's currently in use.
Great. So there is another question about the global pipeline. And since Jillian, you're going, I'll just ask you a question and then I'll go to Andre after that. So do you expect to see multi-disease antigen panel now that we have this humongous pipeline of COVID antigen? So do you see sort of a multi-disease angle to this?
Yeah, so there are, oh, sorry, there's some feedback. So there are already some suppliers of combined antigen tests. So there's been some with flu and SARS-CoV-2. There's also perhaps some other cartridge-based NAT products that may be coming out that are multi-pathogen. I think it's important to keep in mind the performance of these different tests and the use of these different tests. So right now, for example, in flu, the antigen rapid tests don't perform that well. So if you combine them with COVID, it may not get you what you need, but I think it's important to think through what kind of differential diagnosis you're trying to provide when someone presents with respiratory symptoms, which is quite non-specific. And you do want to be able to, if they test negative for COVID, think about what else do they have. So I think there will be a role for these multi-disease tests, but currently I think they're not yet involved in a lot of different algorithms.
Thank you, Jillian. And so Andre, I have a question here which was sent on email. So this was someone wants to know, the audience wants to know basically, what are the key hindrances that you see that negatively impact the usefulness of rapid diagnostic tools? So what do you think are the key aspects that maybe we need training on from the key hindrances?
I think a key factor is going to be sample collection. And I was just answering some of the questions in the Q&A as well, and maybe this sounds like a broken record. We always come back to this, right? This sort of idea of garbage in, garbage out, right? So the quality of that sample is going to be really critical over there. So that's something that I would emphasize. For clinical facilities, the storage of their kits, this is not necessarily an issue for laboratories specifically, but for hospitals and clinics and so on. The storage of kits is another key component. Then the thing that I always tell, and if anyone's ever been with the training with me, I always say this: don't try and remember the procedure. Always look at the instructions for use. And if you have some kind of a job aid that can be put up, then that would really be helpful. And I would always, no matter how good you think you are, it's much easier just to look at something and to perform it, according to the procedure that the manufacturer has recommended. And then I guess the final thing maybe to add as well, I haven't emphasized it enough today, I guess, is the importance of collecting data about these tests, right? So these need to be recorded in some log somewhere so that we can track that against NAT results if those are being sent out for testing as well. But also it's key to see where invalid tests are occurring, and these are key sort of quality indicators. So again, I would say in the post-analytical phase, if we could look at recording those tests in our logbooks so that we can that data can be reviewed and collated. That would be a good point as well.
Great. I think people often think of RDTs as being very simple to administer, and they are, of course, they are in comparison to the lab-based tests. But I think often we underestimate, the nuances of RDT testing. So in line with that, there is one question. Someone has said, please provide a final message on how to ensure quality when rolling out RDTs.
Goodness, that final message, what's that going to be? Sure. Well, if I had to choose one thing, what would I choose? Because they're really, they're all important, right? Otherwise, they wouldn't really be there. I think for this group, if we can just emphasize the training for a moment, and I think there was a question earlier on the chat about, and I think it's a very valid point about how in India the antigen testing have been available for some time already, and that this is already ongoing. So how do we come now, sort of after the point, with some training? And my answer to that was really around supervision, but I wanted to maybe come just back to the point that if we ensure training of our end users, be it during a supervision visit or in a formalized training like this was designed for, we're going to get better results. So that is my take-home message, and not just because I'd like to see the package used, but really that's been my experience in HIV and malaria as well. Trained individuals give better results.
Great. So I think we have a lot of questions right now coming in, but we have time for maybe one more. So I have one question for Gillian, and then maybe one question for Andre, and we'll stop it at that, and maybe remaining we can answer later. So Gillian, I think this is a very interesting question. It's though less sensitive, do you think RDTs are better for mutating pathogens?
So the SARS-CoV-2 has not displayed that much genetic diversity. So most of the PCR tests so far have targeted relatively conserved regions, and I think they've shown good accuracy. Some of the antigen RDTs all target relatively conserved regions in the nucleocapsid, and so thus far we're not seeing escape mutants, but it is something that will need to continue to be monitored as more and more of these tests are rolled out. Yeah, thank you.
Perfect. And Andre, one last question for you, which is a great question, I think. How about a toolkit for clinicians to guide them on how to interpret RDT results? Do you see that as a challenge?
Idea. Yeah, I saw that. That is a fabulous question. And I think some of the challenges are here. The clinicians, obviously, lab workers are also really stretched at this time, but clinicians are really overwhelmed as well, and trying to think of ways that we can condense the important information to deliver that to clinicians in a way that they can consume that easily without taking too much of their time and neglecting their clinical duties would be key. I don't know necessarily that an online way of doing that would be good. I think it requires some thinking, and in other settings, we have developed specific training for clinicians, but we're a little bit behind on this, and I would welcome any suggestions that we can do to get that information out there, because ultimately that's also going to be another component to ensuring that the right people are diagnosed and managed correctly.
Excellent. So I think we are at the hour, and thank you so much to both Gillian and Andre. Thanks for your time, and thank you to all the attendees today. This is our 5th webinar, and please do wait for our next email, which will be telling you about our next webinars. Thank you so much, and have a good Friday and a good weekend. Thanks,
everybody. Goodbye.
Bye.